Welcome back to another video. It's your girl Susan here, back with another amazing video. If you're new, welcome to the channel. My name is Susan and I create videos on faith, lifestyle, dance and fashion. And if you're a returning subscriber, thank you so much for coming back. I know guys, it's been a hot minute, but work has been working and it's been so busy I barely had time to vlog. But a lot of things have changed. I'm currently now in a new department. My last rotation 4 out of 4 pediatrics, and I started last week. That was like my budding week, like just getting to be familiar and know the cases and management and stuff. And right now I'm actually on the timetable. This is my first day of reporting, like officially, like I'm on the timetable. So time check, this is 7:02 I think, and I'm already done. Fit check, I cornered my hair, tied a little bun, yeah, a jumpsuit, my office shoes, and yeah. So basically today I'm gonna be covering NICU. So NICU is basically the neonatal ICU. That's neonatal intensive care unit, and I'm basically going to be covering NICU starts from, I think that should be 13 o'clock up until 16. So I'm already assigned to NICU ward, so I'll be doing like ward rounds from NICU for the next, I think, 1.5 months, and then afterwards I'll go back to the main ward where you'll see all the like cases like asthma, malnutrition, stuff like that. So for now I'll be dealing with neonates, preterms, those kind of things, and yeah, follow me along. I'll try to record as much as I can and teach you guys as much as I can. So at 8 o'clock we have a morning presentation on neonatal sepsis, so that's where I'm gonna be. Yeah, I'll try to vlog and stuff, but for now, like, I'm about to start off for work super early, I know, but yeah, I'd rather be early than late. So yeah, I'll catch you guys later and hope you guys enjoy the video. Bye. Hi guys, good morning. So today is another day. Today is the 4th of June 2024. Time check, this is about 7:15 and I'm just about to go for work. So this is my fit check of the day. Just a jumper, there's a warm top inside, black trousers and some sneakers, yeah, because it's super cold. And today I'm on call. Actually, it's gonna be my first call in pediatrics, so I'm super excited. Of course I'm a bit nervous, but nothing I can't handle. My NICU cover yesterday, you guys, was so horrible. Oh my god, like we had like 27 patients, and then like we literally spent the whole day just seeing patients. Like from morning we finished around 14, then the guys went home and left me because I was covering up to 16, and I had like new admissions that came and they kept me up until like 15:30. That's when I actually got to leave NICU. Like the whole day, you guys, I didn't even eat a single thing. Like the only thing I ate was an apple because I had no time to go for lunch and stuff. Like it was so bad. And then that thing when you're just new and you don't even know what you're really doing, it was just so bad. And there's like so many calculations and stuff that I still have to get my head around. But yeah, I'm getting there slowly. Thankfully it's not as bad because I had my friends, my colleagues to help me out, so I'm really grateful for them. And basically I admitted like 2 patients, but it took me so long because, like, you know, when you're trying to figure out what to do and make a plan. So the first patient that I had admitted was a patient with they had late onset neonatal sepsis. So this child was 13 days old, came from home with a current weight of 1.2 I think, but the birth weight was 3.1, so the weight had been reducing significantly. I think that child should also have some failure to thrive or something like that. So the temperature was like 39 degrees. So we admitted as a case of late onset neonatal sepsis, because for early onset sepsis it should be within 48 to 72 hours, I think. Yeah, after that then it progresses on to late onset. But then correct me if I'm wrong, because I'm still like getting the hang of these things. So for that one, we started the child on second line and IV antibiotics, okay, which is cefotaxime and clostridine. Yeah, cefotaxime and clostridine. So there's a way that you give it. You have to calculate according to the weight of the child, okay. So for both of them, it's usually 50 milligrams per kg body weight, and you give that 8 hourly. So TDS, okay. So cefotaxime and cloxacillin 50 milligrams per kg body weight, IV TDS. And then after that, we also gave the child a bolus of normal saline 20 ml per kg, because this child had some dehydration, okay. So the skin trigger, basically when you pinch the skin, right, it's supposed to go back to its normal position immediately, but for the child it was taking some minutes, like it was taking some seconds, maybe like 3-5 seconds. So had some dehydration, and then also had jaundice of the eyes, okay. So there was also neonatal jaundice, which we had to start phototherapy. There's a whole chart that you have to calculate how to, if the child qualifies for phototherapy and stuff. You can use the Kramer score, or you can use, there's another chart, I've just forgotten the name, I'll put it down here, but yeah, I'll get into it more into detail yeah, when I'm really like getting the hang of everything, and like I'm really solid in my management of PIDS cases. So that was one of the cases. Then the other one was just a suspected meconium plug, because this child had abdominal distension of 1 day and wasn't passing through since birth. So for that one, we just did an enema of 20 ml normal saline, and then we ordered for an X-ray, abdominal ultrasound, and also sent a consultation to surgeons, because just to rule out any Hirschsprung's disease or some obstruction in the intestine, and also put them on IV antibiotics. And for those, we keep them new per oral, okay. So you don't give any food, any breast milk, but you can put them on IV fluids just in case the RBS goes low. So we just put like D5 as a continuous infusion, or half strength diarrheas. So that was it basically. And yeah, I'll try to vlog NICU today, because I'm doing NICU, then I'll come back home and then go back for my course. So I'll try to vlog and run you guys through everything we learn, okay. So stay tuned.
Many hours later.
Hi guys, so time check, this is 19 p.m. and I'm currently at work in the doctor's room. I'm on call, my first call in pediatrics, and so far so good. It hasn't been so bad. I reached here around 16:45. Then I went to get handover from my colleagues. So I found one of my colleagues admitting a case of poisoning. So this child had taken I think it was 500 ml bottle of chlorine. Yeah, so the child ingested chlorine, and basically I found her trying to like cannulate the child and commence IV fluids and also collect bloods for baselines. So this child was a 5-year-old boy who had ingested chlorine, and so for chlorine there's really no antidote for it. So the only thing we can do at this point is just to like collect bloods to check if there's any organ that has been damaged or affected, and also to put the child on IV fluids, which is maintenance fluids. And yeah, so basically how you are calculating the IV fluids is you are giving 100 ml for the first 10 kgs, and then 50 ml for the second 10 kgs, and then the remainder of the kgs you're going to give 20 ml. So this child was weighing 16.6 kg, so we are basically giving him 1,300 ml of IV fluid, that is half strength diarrheas, or Ringer's lactate in 24 hours. That's what we basically did for that child. Drew bloods for baselines and IV fluids, and then yeah, admit for observation, and you counsel the parents on the complications or the prognosis, okay, because the complications may not show now, but they might show later on in life, like the child might be having difficulty swallowing, things like that. So you counsel the parents on that, and yeah, that's what we've done for him. And then I also admitted a case of pneumonia. So this was a 2-year-old child who presented with fever of 39 degrees and difficulty in breathing. We started 2 days ago. So the child on examination had nasal flaring, subcostal recessions, and bronchial breathing or bronchial breath sounds in both the left and right lung bases. Yeah, so for these pneumonia cases, we put the children on Expen and gentamicin. So if the child is less than 3 years old, we just put them on Expen alone. But if they're above 3 years old, then we can put them on Expen and gentamicin. So for this child, we just gave Expen, which is 50,000 international units per kg body weight. So you're going to multiply the 50,000 by your body weight of the patient, and you're gonna give that Expen TDS IV. And then we also gave paracetamol. So paracetamol, you calculate it at 50 milligrams per kg. Body weight, you give QID per oral. So Expen, paracetamol. We also do a chest X-ray, okay. You want to check the lungs, You also make sure to rule out TB, okay? Like that can be also be a cause of the presentation. So rule out TB, do a stool gene expert, because in children it's hard to get sputum. So stool gene expert to rule out TB. Then you also collect blood for your baselines, okay? You check, yeah, your baselines basically. Yeah, don't put IV fluids, okay? Just the antibiotics, paracetamol, the imaging baselines. You monitor the saturations, okay? If the child is desaturating, then you put them on O2, okay? Yeah, so, and yeah, basically that's what we did for the child. So right now I've just been called to go and see another patient. Yeah, so that's where I'm gonna be going now. Then afterwards I need to go to the laboratory because I have to take some blood samples for some of these patients that I admitted, because we need the results for the blood samples tomorrow. So yeah, I hope you guys are enjoying the video. Stay tuned and I'll be sure to vlog as much as I can. Okay, yeah. Good morning guys, welcome back to another day of the vlog. Today is the 6th of June 2024. Time check, this is about 7:10, yeah, 7:10, and I'm just about to leave for work. So today I'll be in the outpatient, just seeing patients in clinic with the seniors, because today is outpatient and also clinic day for pediatrics. So thank God my seniors will be there with us, because if I'm stuck I can ask them. So this is my outfit of the day, just the scrub top, and I put on this top inside. It's kind of like fuzzy inside and warm because it's cold, and the black trousers and sneakers, and yeah. So guys, I'm sorry I didn't vlog yesterday after call, but I was so tired. I got home around, I think around 10 or 11. Yeah, I got home around 10 or 11. Then I had to like freshen up. Then power went at 12 because apparently it's just going to shedding. Yeah, power went at 12, and then around 12 I had my lunch and I went to sleep. And I woke up around, I think that was like 20 p.m. but then there was no electricity because for us power goes from 11 up to 23. So I was gonna like update you guys when I woke up from my sleep, but I just ended up like oversleeping because I was super tired. And yeah, that's how I was like, okay, I'm just gonna update them the following day, which is today. So yeah, basically I think I talked about the patients that had admitted on my call, who were just like a pneumonia patient, a chlorine poisoning patient, and that was basically it. Oh, and Nikki also called me, that was like around midnight, just to admit like a severely dehydrated neonate, 3 days old, and also early onset neonatal sepsis. Yeah, so I think I also mentioned that one. And then later on, around 04 hours, I was awakened to go to NICU again and check on a patient who had changed conditions. So this was a very low birth weight premature child who was born with 700 grams, and the child actually started bleeding from the mouth. So if you know prematurals, the child was born at 27 weeks at 700 grams. So if you know in Zambia, the age of fetal viability is 28 weeks, right? That's when we can at least try to treat the child and save it and help it to thrive. Yeah, but then if it's less than 28 weeks, we barely have like the materials and stuff to help the child cope, because most of its organs are underdeveloped, especially the lungs. So this child was on CPAP. This child, we gave surfactant, vitamin K, but then despite all that, the child still wasn't able to peak. So this child started bleeding from the mouth, and that was obviously a pulmonary hemorrhage which was occurring. And so I had to go and sit with the mother and explain to her again the prognosis and everything. Yeah, so I had to go and sit with the mother again and explain the prognosis of everything, and tell the mother that the outcome wasn't gonna be so good. And yeah, it was sad because the child ended up passing, and I'm about to start off for work. So yeah, I'll update you guys later on during my day and how it goes. And yeah, stay tuned. Hope you're enjoying the video. Bye. Hi guys, welcome back to another day. So today is the 11th of June 2024. Time check, this is around 19:30, and I am on night shift again. I'm on call. So this is my outfit of the day, basically just a scrub. I put on a warm sweater inside, black pants, and my Crocs. Yeah, I'm currently in the doctor's room. So I came for my call at 17 hours. That's when my night shift started, and so far it's just been quiet. I haven't had any admissions, I haven't seen any outpatients, I haven't been called to neonatal ICU, so that's a good thing. Hope it continues being quiet for the rest of the night. Yeah, so I got handover. There were 2 patients that were admitted, both for sickle cell disease or suspected sickle cell disease. So they had collected bloods for sickling tests, and I just had to take them to the lab. I came back from the lab, it was about an hour ago, and I also had to go and follow up blood for one child, fresh frozen plasma, to transfuse the child. But I didn't find the blood ready, so I have to go back maybe in 2 hours or so. So I'm just chilling in the doctor's room, and I thought, why not vlog and share 1 or 2 things with you guys. So I'm so sorry that I haven't been vlogging consistently, but like, yeah, I've just been really busy with neonatal ICU, and also, you know, when you're still new, you're trying to get the hang of a new department, right? So it's basically hard to vlog because you're still also trying to learn and understand what you're doing and how you're managing your patients. So basically I'm in neonatal ICU. I'll be doing that for the next 6 weeks. That's 1 month and a half. Yeah, so basically in neonatal ICU we deal with mostly cases of prematurity. Yeah, so basically in neonatal ICU we deal with cases mostly of prematurity, low birth weight, hypoxic ischemic encephalopathy, that's HIE. We also have like meconium aspiration syndromes. We have like neonatal sepsis, which is also very common. Yes. What else is more common in pediatrics? Dehydration. Yeah, so mostly those kind of cases. So I just want to share a few things on like the prematurity, right? Yeah, so basically prematurity, which is any neonate born before 37 completed weeks of gestation, right? That's before 9 months. And also any neonate weighing less than 2,500 grams, okay? That's going to be your prematurity. So prematurity has gradings, right? Like you can either grade it using the gestation age, or you can grade it using the birth weight. So for us, we mostly use the birth weight here. That's what we use in neonatal ICU. So a neonate less than 1,000 grams, you're going to say that's extreme low birth weight, okay? Extreme low birth weight neonates, that's less than 1,000 grams. And then between 1,000 grams and less than 1,500, that's going to be a very low birth weight, okay? Very low birth weight neonate. And then between 1,500 grams and less than 2,500 grams is going to be your low birth weight neonate, okay? So for all premature babies, for us anyway, what we do here, we have to start them on surfactant, okay? Because you know surfactant is going to help the alveoli not to stick together, and is consequently going to help the child breathe better, okay? So you have to start them on surfactant to make sure that they are able to breathe properly and to at least help their lungs to function, okay? So you start them on surfactant, that's 4 milligrams per kg body weight. Then you can also give them aminophylline, okay? Yeah, a loading dose and a maintenance dose. You also have to collect your bloods for baselines, okay? So full blood count, differential, liver function tests, kidney function tests, blood grouping, yeah, rule out infections and stuff. So you do all that, right? And then you also gonna put these children on, gonna put them on O2, and then you monitor the saturations, of course. You're also gonna do abdominal scans, chest x-rays, okay? Basically for preterm neonates, you also have to start them on TFI, okay? So TFI, that's your total fluid intake, okay? The total fluid intake is going to consist of IV fluids and also the expressed breast milk, or if not breast milk, then formula, okay? So there is actually a table that you use for the TFI, okay? So the lower the birth weight, the higher the TFI. I'm gonna like try to insert the picture of it so that you can kind of understand, because this TFI is used for prematures and also term babies, okay? Normal term babies, you use this to guide you on how you're going to give your fluids and enterior feeds, okay? That's your breast milk or formula for these children. So for premature babies, the TFI can go as high as 200 mils per kg per day, okay? and your EBM can start at 24. Okay, so you start your EBM at 24 mils per kg per day. So for both premature and term babies, you have to note that for the first day of life, you don't start them on EBM, you start them only on dextrose 10%. Okay, yeah, so you start them on dextrose 10%, and that's going to be calculated according to the formula of the TFI. So whether you're gonna start on 40 mils per kg per day or 60 mils per kg per day, you're going to multiply that 60 by the body weight of the child, and the weight that you're using is the highest weight of the child. Okay, so the birth weight, presumably, right? Because that's gonna be like the highest weight. Yeah, so 60 by that birth weight. Then when you get that value, you're going to divide that by 12, because you're going to be giving this D10 or this EBM 2 hourly, right? So whatever you get is gonna be like, for example, maybe it's gonna be 24 mils, you're gonna give that 2 hourly, right? Yeah, so on the first day of life, you just put them on D10. Okay, yeah. If the child is less than 1000 grams, like an extreme low birth weight, then you start on D5. Okay, that's the first day of life. Yeah, because you want to make sure you maintain the blood glucose levels. Okay, so you also have to be checking the RBS profile every like 2 hourly, so you check the RBS. Okay, yeah. So on day 2, anyway, so it depends, people are different. So some of my seniors say you can continue giving the D10 or D5 for the first and second day of life, but my other senior says on day 2, that's when you start the EBM. Okay, so the EBM, which is the expressed breast milk or formula, depending if the mother is not producing breast milk, right? Yeah, so the EBM is gonna start at 24 mils per kg per day. Okay, and you're going to be increasing every day by 24. Okay, so let's say today is day 2, you start EBM at 24, meaning on day 3 you're going to make it 48. Okay, so you'll be increasing by 24 every day. Yeah, that's for the term and preterm babies. But then for HIE it's different, because you have to be increasing by 12 mils. So you start the EBM at 12, then you increase by 12 the following day, then 12 again. But then that one depends also on how you assess the child, right? Like how the child is. If the child is well enough to tolerate starting EBM at 24, then you can still put the EBM at 24. But if not, then you start the EBM at 12 and you increase by 12 every day. Okay, if there's no problem, then you can start as for normal children, you start by 24 and then you increase by 24 every day. Okay, yeah. So the same formula for the EBM is how you're gonna also the same way you calculated for the D10, that's how you're also gonna do for the EBM. Okay, so 24 by the body weight, that's the highest weight the baby has had, divide by 12. Okay, that's what you're gonna give the child in 2 hours. Okay, and then apart from the EBM, you also start your half strength diurese, okay, on also day 2 or day 3. Okay, so the half strength diurese, that's basically your IV fluid, right? Remember we said the TFI is the total fluid intake of the child, that's consisting of IV fluids and the interior feeds, right, which is like the breast milk or the formula, right? So after you calculate your EBM or your formula and you're giving it at so dose, so mils 2 hourly, you also have to calculate your IV fluid, which is your half strength diurese. Okay, so for the half strength diurese, how you're gonna get the figure to use for the formula, you're going to subtract the TFI. For example, you started TFI at 60 mils per kg per day, right? You're going to subtract that 60 from your EBM. Okay, so let's say our EBM is 24, so we're gonna subtract 24 from 60. Okay, and whatever number we get, that's gonna be incorporated into our formula for IV fluids. Okay, so it's gonna be half strength diurese. For example, maybe the number we get is 20. Yeah, so that's gonna be half strength diurese 20 mils per kg per day, and you're also going to use the same 20 multiplied by the birth weight and divide by 12. Okay, yeah, so I don't know, I hope it's making sense to you guys. If not, then just let me know in the comments. I can make a proper video and explain it thoroughly. Okay, yeah, it also took me a while to learn this because it was so confusing, but after some time, yeah, it becomes easier as the more you practice. Okay, so yeah, that's gonna be how we're gonna be giving our TFI. And basically for TFI, we want to ensure that we continue to give it until the only thing that we're giving the child is breast milk. Okay, and the IV fluid has to gradually keep reducing. Okay, so the more you give, like the more days you advanced in giving, you have to ensure that the EBM is increasing, but the TFI, you have to ensure that the EBM is increasing, but the IV fluid, that's the half strength diurese, is reducing until it reaches to 0 and the child only remains on EBM, and that's when we are going to say the child is on full EBM. Okay, that's basically going to be the maximum dose that child is going to be taking. Hi guys, welcome back to another day of the vlog. Today is the 14th of June. This should be almost 7:30 and I'm on my way for work. Yeah, outfit check. It's cold, so you know the vibe. Just the top, cute little top, jeans, and my boots, winter boots. Yeah, so my call, where did I end the vlog? Yeah, I ended the vlog on my last call. And it was really hectic. It got so busy from 22 up until 6. I was up, you guys, like just running back to forth from NICU then to the main pediatrics ward. It was so busy. I had so many like emergency cases that came, and I also had one mortality which was really sad. It was a case of severe malnutrition with severe generalized body edema. Like this baby was swelling the entire body, and then he also developed DIC and sepsis, right? So we ordered FFP for him, but then it couldn't be ready on time. I had the mortality that was around 02, and then like from 22 up until before that mortality, I kept having like admissions, patients coming in with like pneumonias. What else? I had pharyngotonsillitis, febrile seizures. What else? Yeah, most of them were just like pneumonias and upper respiratory tract infections. Like they just kept coming for, I don't know what reason. Parents decided to bring their child to the hospital with an upper respiratory tract infection at 3 in the morning in this cold. But anyway, it is our job. So yeah, I was up the whole night seeing those patients. The NICU called me to admit one macrosomic baby and also a very low birth weight prematurity with sepsis, yeah, and respiratory distress syndrome. So that was basically my call. Yeah, and I got home really tired, and to make it worse, there was no power when I got home. So currently now there's no power. Apparently we're having load shedding for 18 hours of a day now. It's gonna be back at 18 hours up until midnight and then cut again. So yeah, today I'm just covering NICU. I'm doing the round in NICU and covering NICU, so I'll bring you guys along. And yeah, I hope you guys are enjoying the video so far, and yeah, bye.
So this was basically me in the outpatient, and here it was a quiet day. This was a Saturday. I was basically seeing patients who just had upper respiratory tract infections, so I was just prescribing cough syrups, paracetamol.
Hi guys, welcome back to another day of the vlog. So today is the 16th of June, Father's Day. Happy Father's Day to every father, big or small. We appreciate you, we love you so much. So yeah, today is the 16th of June. Time check, this is around 12:30-ish. Yeah, and I'm currently at the hospital at work. I'm currently in the outpatient department, that's OPD, Pediatrics, and I'm basically just covering the entire OPD and the wards and neonatal ICU if needed. So currently it's been a quiet day. Like it hasn't been so busy. The only patients I've been seeing are mostly like upper respiratory tract infections, pharyngotonsillitis. So the management for those is not anything hard. For the pharyngotonsillitis, you just want to make sure you check for any lymphadenopathy or cervical lymphadenopathy, right? Yeah, you check under the neck, under the chin area. You check by the sides of the neck if there's any lymph nodes that are swollen. Yeah, and then you also inspect the oral cavity. Okay, you check the throat area, to be specific. You want to check if the tonsils are enlarged or inflamed or reddened, or just check for tonsillitis. Okay, so basically for pharyngotonsillitis, we give them a stacked dose of benzathine penicillin. That's 600,000 international units. IM or IV start. Okay, so that's gonna be enough to like clear that out. And then afterwards you can also put them on paracetamol, either syrup or tablets according to the age of the baby. Okay, you calculate it 50 milligrams per kg body weight. Okay, so yeah, put Panadol, give the start dose of benzathine penicillin. Then you can also encourage if the child is big enough, you can also encourage the parent to encourage the child to do warm salt water gargles. Okay, so warm water, salt, and then the gargle it. Okay, that will help. That's for the pharyngeal tonsillitis. For the upper respiratory tract infection, basically they come with cough, flu, fevers. So for the fever, again, you give Panadol. Okay, because Panadol is not only an anti-pain, it also relieves fevers. Okay, so Panadol at 50 milligrams per kg body weight, you're going to give that TDS or preferably QID, okay, just for 3 days. Then you also put them on a cough syrup. So for us here, we have the pediatric version of the Trifen cough syrup. That's what we give, either 2.5 mils or 5 mils according to the age of the baby. Okay, and then what else? Yeah, you can also put vitamin C if you want, but really the Panadol and cough syrup are enough because the body is able to clear out the infection on its own. Okay, so you don't really need to do much. Yeah, so basically that's what I've been seeing. And then NICU hasn't called me. They are quiet, so I hope they stay quiet because I'm here until 17, so I only have like 4 more hours. Yeah, I hope it stays quiet until then. And then ICU called me to review a patient, but then I think they made a mistake because that baby is 7 months old and is a post small bowel repair due to perforation. Yeah, so that's supposed to be a surgical review, but I don't know why they called me to review the baby. Apparently the baby is NPO, but he opened bowels. The baby is new PO, but he started opening bowels this morning. He passed stool twice, so I told them to contact the surgeons because I can't go as a pediatrician and go and commence the child on feeds, right? They'll start this hospital politics and stuff, so let the surgeons do that. I just handled my pediatrics part, checked the chest, the airway, the heart, which is all okay. So yeah, I'm currently back in the doctor's room. I'm just having a cup of tea. Yeah, so if anything happens, I'll fill you guys in, but for now I think let me prepare another part of the vlog that's gonna be interesting, and I'm also gonna be sharing something that I'm super excited to share with you guys. Just an advancement in my career, so stay tuned for that. And I think I'll end the vlog here. I hope you guys have enjoyed it. I hope you've learned a thing or two, and please do subscribe. Stay tuned. Okay, let's get to 1,000 subscribers. Giveaway at 1,000 subscribers. Okay, and yeah, I'll see you guys in my next video. I love you so much. Thank you so much for your support. Thank you for watching, and see you next time. Bye.
I don't know how we got here, but been going through the phases.